cancers detected every year in India, and it's three times more common in male than women. Because I think smokeless tobacco, as we all know, because people tend to think it is better than smoking, and if you see the incidence of oral cancer is higher in India because the cause association time required between smokeless tobacco and smoking tobacco is much lesser. People who chew tobacco, smokeless tobacco, tend to develop within 2 years of their starting of the habit, when smokers tend to develop it after 10-15 years. So that is why I think, and they can chew, but chewing tobacco you can sit and chew. Smoking is not is so easy to as a habit to do it in public. Whereas smokeless tobacco is more easily doable and it's accepted, and people think it is safer. So which is a myth, and that is why I think men are using it more. And as I told you, cause association time is lesser. So the incidence of and youth are getting into chewing at early age. So the early cancers, and it's increasing in people, and female awareness is increasing. Probably that is the reason, and education plays a very important role. I think more women education-driven programs and all has reduced the incidence in women.
Dr. Kannan, in your many years of experience, are you seeing a stage shift also? Are people coming with more advanced stages of cancer nowadays, especially in your youth, because of the usage of oral tobacco? What do you think?
So stage migration is there. More, if we see 100 patients, out of which 60 to 80 would be on stage 3, stage 4. Which this I mean if the lesion is less than 2 centimeters, it's a smaller tumor. If it has gone to the bone, skin, these are advanced tumors. So most of the patients reach us only when it is advanced. Whether it has come to the skin, there is a lump in the neck. Whenever they have a small ulcers in the mouth, they think it's because of the chewing habits and they start ignoring it. Particularly, there are two things which causes cancer. One is tobacco, other is aracanite. Aracanite is the aracanin which causes smaller ulcers in the mouth, and then it causes fibrosis, then it goes on. So they take these things as normal, and then they start ignoring it. So they leave the stage when it is very small, very easily treatable, and come to us at an advanced stage. So people out of our OPD, 60 to 80% would be advanced tumors.
You have to understand that unless a surgery is done, or in early stage radiation is okay, but in an advanced stage surgery is actually, without surgery it's not possible to cure. In stage 4 the cure rates are less than 20%, in stage 3 it is less than 30 to 40%. So it's so much important that we have detection of the cancers much earlier, in maybe pre-cancerous, or if not at least in stage 1 and stage 2. Dr. Sandeep, what are the areas in India where you see that the incidence is much more than the other areas, and why it could be?
Yes, like you mentioned, India is the the major problem is oral cancer, where we see a very, very high number. But then this is seen more prevalent in the north. And in the north, I would say the northeast, we see the major amount of oral cancers. Mostly this is because of the cultural habits. That is, in the northeast, it is deemed culturally proper. When somebody comes to your house, you offer them aracanut, betel leaf, and of course, just these two will not kind of potentiate the problem, but then they also add slake lime to it. So this is something which is very, very commonly seen in the northeast. But then, not to be outdone is also the northern belt and Gujarat, where now we are seeing a very high prevalence of the smokeless tobacco in the form of gutka, which is being used. One thing which Dr. Naveen mentioned is that it's very, very culturally, I would say it's very easily, you can mask it. That is, you consider it culturally appropriate not to smoke or something in front of the elders, but then you can always chew your tobacco. So this is one of the main reasons.
So coming to oral cancer screening, we need to understand what is the difference between screening and what is the difference between screening and diagnosis. Dr. Ratna Devi ma'am, can you tell the audience what is screening and how is it different from diagnosis?
Screening is definitely different from diagnosis. Search of abnormality in a healthy individual with no symptoms is called screening. So when you screen, you are trying to see whether there is any abnormality. This is done in a larger population and the tests are not very specific. Only if there is an abnormality you find in the screening, you go ahead, get more specific. You diagnose it to confirm with a biopsy or imaging, and which helps you to pinch the diagnosis is the diagnostic part. So totally a healthy individual, when you search in a healthy individual who has no symptoms, that is screening. This helps in the early detection of cancer and thereby definite high probability of cure in these individuals. So in our country, I think it is very, very essential we go ahead with this early cancer detection, especially with the oral cancer, and the awareness is very, very important.
Professor Abna, can you tell us why is oral cancer screening so much important, and what are the benefits of oral cancer screening?
I would say the benefits are actually three in number. One is that we learn to identify, or we get to see, identify precancerous lesions. When we identify precancerous lesions, there can be an intervention, there can be, that will help us, stem the problem and nip the problem in the bud itself before it develops into cancer. Second would be the early detection of an established cancer before it becomes symptomatic. Screening allows us to detect cancers early. We have seen that happening in many other sites, and a typical example of that is breast, where we know that early detection, a screening program helps in early detection or detection of disease in an earlier stage. And the third and very important reason would be that this would be an opportunity for doctors to counsel patients, because we have discussed repeatedly that these issues arise because of habits, and this is an opportunity for the healthcare professional to counsel the patient to give up these habits, and we do know that giving up habits is beneficial.
Right. So that is very important. The screening doesn't only mean a physical examination, it also can bring a behavioral change because of the counseling that is involved with the clinician and between the individual who has gone for the screening. So Dr. Naveen, who are the individuals you would recommend to undergo oral cancer screening?
Screening has to be targeted, as we know, because the outcomes for mass screening can help, but if your screening is targeted at high risk individuals who are smokers, alcoholics, can identify and definitely reduce the risk of death by oral cancers in patients who are at risk of oral cancer, who use tobacco and alcohol. There was a study from India which showed that you could reduce 1 in 10 people by Shankar Narayan, that if you screen high risk individuals, you can reduce the chance of death in 1 in 10 person who used this thing. But when they screen mass public, the effect was not that effective. So screening high risk individuals is very important, especially smokers, on alcoholics, and people who use both. Screening high risk individuals is the most important thing, I feel.
Dr. Kannan, what is it that if a person has not smoked, they only are at risk, or are there any other risk populations that they also should go and meet a doctor for an oral examination or oral screening?
So mainly, as we all know, 5 things will cause pre-malignant lesions or cancerous lesions: smoking, smokeless tobacco, chewing smokeless tobacco, alcohol, betel nut without tobacco will also cause cancer. Faulty sexual habits, HPV related things can cause cancer. These are the 5 things which mainly cause cancer. These people are, as Naveen told, targeted screening needs to be done. Other than that, people who have oral submucosal fibrosis for other reasons, lichen planus, ulcers which is not healing for a long time, these people should also have regular screening. This was it.
So, Dr. Sandeep, can you just explain what is an oral cancer screening procedure? What is, suppose someone comes to the OPD, how much time it may take, and what are the procedures they have to undergo?
Okay, briefly speaking, I mean, like we have already spoken about the purpose of the oral cancer screening and who should screen. That is anybody who is above the age of 30 should undergo oral cancer screening. But then we also should stratify, like, what is my risk factor. Now, suppose the person is a smoker, the person drinks, patient has got precancerous lesions like leukoplakia, erythroplakia, patient is positive for HPV. These come into the high risk category. Also patients who have a family history of malignancy. Now, what happens is when these patients, we stratify the risk factors, what they do is when they come to us, first they register and they're immediately seen by a senior head neck oncosurgeon who will do a visual examination first. Then we'll also palpate the whole entire oral cavity, giving a tactile examination of the oral cavity. If necessary, we'll do some kind of OPD procedure, brush biopsy, or we might even stain the lesion with toluidine blue to see whether these lesions have a tendency to progress towards malignancy, or they have some kind of malignancy hidden in it. Then once we screen and we examine the patient, if deemed necessary, we'll ask for further investigations, as in the form of imaging. And once the imaging comes in, which doesn't take much time, it'll say the whole procedure would take somewhere around 3 hours from the start to the end, and if necessary within that, we would also do a biopsy.
So in that context, can Dr. Kannan, can you explain? There is a lot of negative thought discussions about biopsy and cancer. So we all understand that biopsy is so much integral in diagnosis. So all this in media also there is all discussion happening. Can you just enlighten the audience about why biopsy is important and that how is it not? How is it harmless?
Lot of patients who come to us ask us, if I do a biopsy, will the lesion progress? Will this lesion spread to other parts of the body? And will it increase in size? So if you don't do biopsy also, if it is a cancerous lesion, it's going to increase in size, it's going to spread. Biopsy per se will not increase the malignant potential, will not increase the aggressiveness of the malignancy. So doing a biopsy in oral cancer will tell us whether there is cancer or not, will tell us whether it's a pre-malignant lesion or not, will tell us how to follow up the patient in a pre-malignant lesion. For example, if it's just a leukoplakia which is homogeneous, we can have a relaxed follow-up. If it is a proliferative verrucous hyperplasia, then you would have a close follow-up. So doing a biopsy per se will not increase the aggressiveness of the tumor, and it will guide us on the further treatment options. So biopsy is very important in oral cancer.
So as we saw, there is this association between Apollo Cancer Centers and Isha Foundation to come forward in oral cancer screening. So Dr. Mahathi, how do you think it is important for how does the Miracle of Mind app intend to find out or to induce a change in the person who is undergoing oral cancer screening?
Yeah, so Isha Yoga offers several practices that improve well-being of the patient, and so by helping in emotional regulation and increasing self-awareness. These are the main things that help in habit breaking, like tobacco addiction. And why Miracle of Mind app? So this is a simple, effective 7-minute practice designed by Sadhguru. It can be downloaded by anybody. It's already been downloaded by 2 million users and are being used regularly. And so this can be done by anyone, anytime, anywhere. And so it can be fit into everyone's busy schedule also. So if we equip the general population with something, better tool, that is like a better tool, an effective tool like meditation, the main reason for adopting these practices is because it is a means to cope with stress. So when meditation can effectively tackle stress and anxiety, the need to use substances, additional substances, will fall off on its own. Also, when through meditation, if the general population experiences something bigger, their need to explore other substances to have that similar kind of experiences will fall off on its own. And so when meditation moves, like generally after you move from compulsiveness to consciousness. So when you do a conscious decision in everything, factors like peer pressure, social desirability also fall off. Yeah, and I would just like to add one more point in the screening. So even sharp tooth, if undiagnosed, that also causes leads to oral cancer. This the general population must note, and so any decay tooth fractured for a long time, so it will be impinging on the tongue, and they will be just not like they will be delaying going to the dentist.
And that is so much important because they never suspect themselves to be
Yeah.
at risk.
Yeah.
So we do have people who have never smoked and then
Yeah. So non-habit related oral cancer is because of sharp tooth, one of the main reasons.
Correct. So this compulsion to have the substance because of whatever reason, it may be peer pressure, it may be loneliness. It has been said loneliness is like it's called a global epidemic, and loneliness is as bad as smoking 15 cigarettes per day. It has been said by WHO. So the loneliness is increasing. People are getting into addiction to just break their loneliness. So that conscious effort would make a difference in their behavioral patterns. So now that we have some time, can Dr. Ratna ma'am, can you say just a little bit more about radiation? How does it differ between early stage and late stage? If there is someone who is diagnosed with early stage and late stage, how does it differ in radiation practices?
Radiation plays a very integral role in the treatment of oral cancer, surgery and radiation. And in early stages, if it is operable, I think surgery is the first day of the treatment. In an inoperable condition, say for example, if the patient is medically not fit for a surgery, then I think we have to move ahead with the radical radiotherapy plus or minus chemotherapy depending upon the type of cancer, grade of cancer, stage of cancer. So all these are very important before we initiate the treatment. Radiation, the evolution of radiation has been wonderful in the last 2-3 decades. From 2D, from surface marking, we moved on to high precision, 3D to high precision like IMRT, IGRT. Then we moved on to the radiosurgery called CyberKnife, then now we are with proton. So more and more precise radiotherapy has definitely made a big change in the radiotherapy treatment. It has made the patient, the travel, the journey of the treatment has become much more easier and less side effects, more patient compliance has improved. So definitely the xerostomia, we're not seeing it anymore with the high-end radiotherapy. And definitely so such evolution happened with surgeons also. So we have developed beautifully in the field of oncology, both surgical, radiation, and of course with the medical oncology also. As the cancer is increasing, so is our science increasing. We are seeing more and more success rate. And the take-home message should be early detection of cancer, cancer screening, especially if you are habit-related.
And Dr. Ratna, if you can just add 1 or 2 words on proton therapy as part of the treatment, because it's an important part nowadays in oral cancer treatment.
So I'd like to first tell the media here about proton therapy. Proton therapy is a highly specialized form of radiation, a more advanced form of radiation, which works in 2 manners. One is by reducing the dose that is being received by the normal structures, and that makes the toxicity of treatment much less. And the second is by the way the energy is deposited in the tumor, which leads to a different way of damaging the DNA of the tumor called double-strand DNA breaks. The DNA has 2 strands, and when patients are treated with proton therapy, more often both the strands are damaged instead of a single-strand DNA break. Because of that, proton therapy leads to less toxicity in treating a number of cancers, or better outcomes in some other cancers, and in many cancers it leads to both. That means reduction in toxicity and improvement in outcome. At the Proton Center, we have been particularly interested in seeing the application of proton therapy in oral cancers. You will understand why, because it is the most common cancer affecting Indian men. And what we have noted in proton therapy is, number 1, the toxicity of the treatment becomes much less because the dose going to the normal structures, such as the lining of the cheek and that of the swallowing muscles, the voice box, is much less in proton therapy. And the other very encouraging outcome that we are seeing is that the outcomes of treatment also seem to be better in patients who are treated with proton therapy for oral cancer. As Dr. Ratnadevi mentioned, the primary treatment of oral cancer is surgery, and the role of radiation and proton therapy comes in, number one, as an adjunct to surgery, that means after surgery, or in patients in whom inoperable tumors are there, that means surgery cannot be performed. And in both these, we have seen both the reduction of toxicity and improvement in results.
So just before we finish, I want each one of the panelists to tell what the one message they would like to give to the media regarding oral cancer screening, starting from here, Dr. Sandeep. Regarding this program and in whole, what do you feel the oral cancer screening, what should be the take-home message for the media and for all of us?
The take-home message should be that everyone, irrespective of the risk factor, if they are above the age of 30, should undergo oral cancer screening. And it's a very non-invasive, simple procedure.
With the press, I would, because they are the people who are going to spread the message. Still today, 80% of the cancers which come to, oral cancers will come to our clinic are advanced cancers, treatment of which can be seen obviously when people are walking around. If we are able to detect these cancers in an early stage, if we, with the help of awareness, definitely the treatment and outcomes and functional outcomes are very, very good. So early detection definitely helps in better outcomes. So that is the take-home message from my side.
Dr. Sapna?
I would like to reiterate that oral cancer is the most common cancer amongst Indian men. It should deserve a lot of attention from the media. Do you know that when Indians, in the countries where Indian diaspora is present, there the oral cancer risk increases. That means wherever more Indians go, there the risk of oral cancer increases. That is how important it is for, how common it is in Indian men. And really the media has a very important role in drawing attention to it and in promoting healthy habits as well as screening.
Dr. Mahanti?
So I would like to again reiterate that do not ignore a long-standing fracture or a sharp tooth. It is very dangerous.
Dr. Ratnadevi, ma'am?
Oral cancer screening and tobacco cessation, that should be the take-home message.
Dr. Kannan?
80% of the oral cancers are habit related, so stopping the habit is quite important and media should play a role in it. If you have a smaller lesion, cure rate is faster, so early detection and stopping the habits.
Right, so with this we come to the end of this panel discussion. So whenever we speak about oral cancer screening or any screening, we all think it is for others. Please, all of you who are above 30 years, get it done. It is okay, even if you don't visit an onco surgeon, you can meet a oral surgeon or anyone nearby, get it done. And it's always better, and we all know that screening is always better than diagnosis. And I invite all of you to be the message bearers for this important message that we are giving, that oral cancer, being the most common cancer in men, deserves more attention, and it can be prevented, it can be detected in early stages and can be cured wonderfully well with the treatment modalities that we all have here. Thank you so much. I thank all the panelists for the interesting discussion. Thank you so much.
Cancer screening launch பண்ணியிருக்கிறோம். Oral cancers வந்து தமிழ்நாட்டில் ரொம்ப அதிக அளவில் பாதிக்கப்படுறாங்க. ஆண்கள் பெண்களை காட்டிலும் அதிக பாதிக்கப்படுறாங்க. இது எதனாலன்னு பார்த்தீங்கன்னா புகையிலை வந்து சூ பண்ணுறது ரொம்ப காமன். நம்ம சவுத்துலலாம் பார்த்தீங்கன்னா, டவுன் சவுத்துலலாம் பார்த்தீங்கன்னா புகையிலை, இப்போ வந்து என்னுடைய பேஷண்ட் ஒருத்தவங்க வந்து பல்லு வந்து சொத்தையாக இருந்ததுக்கு பன்னீர் புகையிலை போடுறேன் அப்படின்னு சொல்கிறாங்க. நமக்கு வந்து இந்த கல்ச்சரே இருக்குது. இந்த வெத்தலை பாக்கு போடுறது, இந்த சுண்ணாம்பு தடவுறது, அதுலேயே புகையிலை போடுறது மாதிரி அந்த கல்ச்சர் நம்ம இந்தியாவில் ரொம்ப காமனாக இருக்குது. இதுவே வந்து கேன்சரை வரவழைக்கக்கூடிய ஒரு ஹேபிட் அப்படிங்கிறது தெரிய வந்திருக்கு. ஸோ அதனால இப்போ கேன்சர் ஸ்க்ரீனிங் பண்ணுறதுனால எப்படி இதை ப்ரிவெண்ட் பண்ண முடியும் அப்படின்னா, ரெகுலராக நம்ம இந்த ஹேபிட் உள்ளவங்க ஸ்க்ரீன் பண்ணும்போது சிம்பிள் தான். வெறும் விஷுவல் எக்ஸாமினேஷனும் ஹிஸ்ட்ரியும் கவுன்சிலிங்கும் தான் நடக்கும் இந்த ஸ்க்ரீனிங்கில். இதுலேயே ஏதாவது ப்ரீ கேன்சரஸ், அதாவது கேன்சருக்கு முந்தைய ஸ்டேஜ்லேயே இதை நம்ம கண்டுபிடிச்சிடலாம். இது வந்து
வெள்ளை பேட்ச் மாதிரி இருக்கலாம், இல்லை சிகப்பான எரித்ரோபிளேக்கியாவாக இருக்கலாம், இல்லை லைக்கன் பிளானஸ் மாதிரி இருக்கலாம். இதை நம்ம இந்த நிலையிலேயே கண்டுபிடிச்சிட்டோம்னா கம்ப்ளீட் கியூர் கிடைக்கிறதுக்கான வாய்ப்புகள் நம்ம டெஃபினட்டாக இன்க்ரீஸ் பண்ணுறோம். அதனால் இந்த ஓரல் ஸ்க்ரீனிங்கிறது ரொம்ப ரொம்ப இம்பார்ட்டண்ட்டு. நம்ம மற்ற இதுக்கெல்லாம் வந்து ஸ்க்ரீனிங், இப்போ பிரெஸ்ட் கேன்சருக்கு வந்து மேமோகிராம் பண்ணணும், அந்த மாதிரி பேப்ஸ்மியர் பண்ணணும், சர்வைக்கல் கேன்சருக்கு, அந்த மாதிரி இதுவும் ரொம்ப இம்பார்ட்டண்ட்டான ஸ்க்ரீனிங் டூலாக இருக்குது. இது பண்ணுறதன் மூலயமா நம்ம கேன்சரை முன்னாடியே கண்டுபிடிக்கிறதன் மூலயமா நம்ம காப்பாற்றக்கூடிய ப்ராபபிலிட்டி டெஃபினட்டாக இன்க்ரீஸ் பண்ணுறோம். இது வந்து 30 வயதுக்கு மேற்பட்டவர்கள். இப்போ வந்து ஜென்ரலாக ஒரு மித் இருக்குது, நான் வந்து யங்காக இருக்கேன் எனக்கு வராது அப்படிங்கிறதெல்லாம் உண்மை கிடையாது. ஹேபிட் வந்து இப்போ பார்த்தீங்கன்னா ஸ்கூல் பசங்கள்லாம் கூட போட ஆரம்பிச்சிட்டாங்க. அவங்களுக்கு வந்து ஈஸி அவைலபிலிட்டி, இது வந்து ஈஸியாக கிடைக்கிறது, டிஃப்ரெண்ட் நேம்ஸில் கிடைக்குது. இதை வந்து இதை யூஸ் பண்ணுறது மூலிமா நம்ம அந்த மியூக்கோசாவை நம்ம டேமேஜ் பண்ணுறோம். டேமேஜ் பண்ணுறதுனால இந்த யங் இண்டிவிஜுவல்ஸுமே இந்த கேன்சருக்கு அதிகபட்சத்தில் பாதிக்கப்படுறாங்க. ஸோ 30 வயதுக்கு மேற்பட்டவர்கள், இந்த மாதிரி ஹேபிட் உள்ளவர்கள், டுபாக்கோ சூவிங் அண்ட் ஆல்கஹால் உள்ளவர்கள், ஹெச்பிவி வைரஸ் உள்ளவர்கள், புவர் டென்டல் ஹைஜீன் உள்ளவர்கள், இவங்களுக்கு எல்லாமே இந்த ஸ்க்ரீனிங் ரொம்ப ரொம்ப அவசியமாகும். ஹெரிடிட்ரி ரீசன்ஸ் கொஞ்சம் குறைவு தாங்க இந்த வகையான கேன்சர்ல. ஓவரால் கேன்சர் 30%. இப்போ ஓவரால் கேன்சர் 100% எடுத்துக்கிட்டிங்கன்னா வெறும் ஓரல் கேன்சர்ஸே 30% வரும். என்னங்க?
ஆமா, ஷார்ப் டீத்னா இப்போ வந்துட்டு கூரான பல்லு, உடஞ்சிருக்கு, சொத்த பல்லு ரொம்ப நாளா இருக்கும். ஸோ அதை வந்துட்டு கண்டுக்காம விட்டுருவாங்க. அது நாக்குல, பின்னாடி நாக்குல இல்லை சதையில எங்கேயாவது குத்திக்கிட்டே இருக்கும். சின்னதாக புண்ணு வரும், மறைஞ்சு போயிடும். திருப்பி கொஞ்ச நாள் கழிச்சு சின்னதாக வரும், மறைஞ்சு போயிடும். பட் ஒரு பாயிண்ட்ல பார்த்தீங்கன்னா ஒரு 10 நாளைக்கு மேலே அப்படியே இருந்துடும். அப்போ தான் வருவாங்க. ஸோ அந்த ஒரு 2 வாரத்துக்கு மேலே ஒரு புண்ணு சரியாகாமல் இருக்குது அப்படின்னா நம்ம அதை சதை பரிசோதனை பண்ணியே ஆகும். ஸோ அந்த அளவுக்கு நம்ம விடக்கூடாது. ஒரு சொத்தப்பல் இருக்குது, உடஞ்சிருக்கு, அங்கங்கே புண்ணு வருதுன்னா ஃபஸ்ட்டே போய் அதை சரி பண்ணிட்டா அது தடுக்கிறது பெட்டர் ஆல்வேஸ்.
7 மினிட்ஸ் மெடிடேஷன்ல என்ன பண்ண முடியும்?
ஆமாம். ஸோ இப்போ தமிழில் இந்த மெடிடேஷனில் வந்துட்டு ஸோ லைக் இட்ஸ் ஆப் மூலமாக ஃப்ரீயாக டவுன்லோட் பண்ணிக்கலாம். ஸோ 7 மினிட்ஸில் வந்துட்டு சத்குருவே கைட் பண்ணுவார் எப்படி அந்த மெடிடேஷன் பண்ணணும் அப்படிங்கிறது. ஸோ இப்போ ஈஷா யோகாவில் நிறைய ப்ராக்டிசஸ் இருக்குது, 21 மினிட்ஸ்க்கு 12 மினிட்ஸுக்கு அப்படின்னு. பட் இப்போ இது 7 மினிட்ஸுங்கிறதுனால எல்லாராலையும் எளிதாக பண்ண முடியும். ஸோ நம்ம பிஸி லைஃப் ஸ்கெடியூலில் கூட நம்ம வந்துட்டு இது பண்ண முடியும். ஸோ அந்த ஆப் நம்ம டவுன்லோட் பண்ணிவிட்டு நம்மளே வந்துட்டு அந்த வாய்ஸ் ஓவர் கைடன்ஸை கேட்டு நம்மளால் பண்ண முடியும். ஆல்ரெடி 2 மில்லியன் டவுன்லோட்ஸ் ஆகிருக்கு, எல்லோரும் பண்ணிகிட்டு இருக்காங்க உலகெங்கும். ஸோ நம்மளும் இது போல் இதுக்கு யூஸ் பண்ணிக்கலாம்.
ஸ்க்ரீனிங் வந்து உள்ளே வந்தாங்கன்னாக்கா ஓரல் ஸ்க்ரீனிங் தான் பண்ணணும். விஷுவல் ஸ்க்ரீனிங் பண்ணுறதுக்கு 10 நிமிஷத்துக்கு மேலே ஆகும். அதுக்கு மேலே நம்ம சஸ்பீஷியஸ் ஏதாவது சந்தேகமாக இருந்துச்சுன்னா தான் நம்ம அதை பயாப்சி பண்ணி பார்க்கணும். ஓவரால் ஸ்க்ரீனிங் டைம் 10 நிமிஷத்துக்கு மேலே தேவை. மேல் அண்ட் ஃபீமேலுக்கு என்ன ரேஷியோ?
மேல் ப்ரிபாண்டரன்ஸ் நிறைய இருக்குது, 2:1 மாதிரி.
2:2
மேல் தான் அது. என்னப்பா? டொபாக்கோ செசேஷன்
5 ஹேபிட்டை ஸ்டாப் பண்ணணும். சிகரெட் பிடிக்கக்கூடாது, ஆல்கஹால் எடுக்கக்கூடாது, புகையில சூ பண்ணக்கூடாது, பாக்கு போடக்கூடாது, ஓரல் செக்ஸ் அவாய்ட். இந்த 5 ஹேபிட் ரொம்ப இம்பார்ட்டன்ட். எப்போ சின்னமாக கொண்டு வருதோ, வெள்ளையா பேட்ச் வருதோ உடனே டாக்டர் கிட்ட போகணும். மற்ற கேன்சரை கம்பேர் பண்ணி ஓரல் கேன்சர் டக்குன்னு வராது. வெள்ளை பேட்ச் வரும், சிகப்பாகும், திக்காகும், அதுக்கப்புறம் தான் கேன்சர் வரும். ஸோ நம்ம இனிஷியல் ஸ்டேஜில் வரதுக்கு முன்னாடியே பார்த்தோம்னா